Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about glaucoma patients. Twinzol brings patients to the targeted IOP regardless of their baseline. Twinzol reduces the IOP by 30% for patients whom IOP is more than 25 mm mercury. And for those whom IOP is more than 30 mm mercury, Twinzol could reduce it up to 50% of the IOP. Another product for your glaucoma patients is Alpha Nova. Alpha Nova is the perfect add-on therapy with a superior neuroprotective effect, along with less incidence of ocular allergy as Alpha Nova is preserved with sodium purite. Finally, I would like to remind you with OcuGuard, a tailored formula of vitamins, minerals, and herbs. Thank you for your time.
Episode of Glaucomatology, CME 2020. How often do in our practices and in our hospitals see cases which are not sure, we are not sure of their diagnosis? Cases with advanced cupping but with perfectly nice visual fields and perfectly low intraocular pressures in different visits. How often do we see cases which come to our clinics with the treatment of glaucoma and we think that they are not glaucomatous at all? And then if we have our glaucoma patients, how often do we think that this glaucoma treatment, is it enough or not enough? Is this case progressing or not progressing? Is this case improving or no? So these are various questions which needs very well organized mental workup, which is the subject and the topic of our episode this evening. This evening we are actually honored and pleased by two of the beautiful minds of glaucoma management in Egypt. Both of them have a very long history in thinking and building up structured plans for glaucoma management and detection. We have Professor Dr. Adel Abdel-Shafik, Professor of Ophthalmology at Ain Shams University, and we have Professor Dr. Nader Bayoumi, Professor of Ophthalmology at Alexandria University. The first talk will be by Dr. Nader, who is going to talk about the clinical approach to glaucoma. And both of them actually were behind the first thinking of this title of the episodes, is the mental workup for glaucoma. So I expect to have a very rich session, informative for all of us. Dr. Nader.
Thank you very, very much, dear sir. I'm really honored by my participation in this webinar, and I hope the material presented would be of interest to the audience and they would benefit from it. So if you would allow me to start. So now I'm sharing my screen. I think it's obvious to everyone. I think the voice is okay, so allow me to start. Now, my talk today is going to be about the clinical approach to glaucoma. Please let me quote a statement from one of my mentors. Today I'll be discussing, of course, is this glaucoma, the diagnosis glaucoma versus no glaucoma. Please allow me to quote this statement from one of my mentors, which used to teach us that to miss a diagnosis of glaucoma is a mistake. Definitely yes. But to wrongly diagnose glaucoma in a patient who is not glaucomatous is a crime, meaning that the mental, social, and the drug burden of the glaucoma to a patient who is not glaucomatous is really, really a very bad thing. So let's try to avoid this mistake of diagnosing glaucoma in a patient who is not glaucomatous, and at the same time not miss the diagnosis of glaucoma. So in a lot of cases, like Professor Khalil introduced, we get a phone call from a colleague mentioning that I have that patient that I'm following for the past 3 years, the CD ratio and the optic nerve generally, and the fields are stable. So which glaucoma drug should I prescribe at this point? So I start thinking, is this information really suggestive of glaucoma? I go back to the guidelines and the evidence base, which tells me that the following. First, glaucoma, it's a progressive disease. Let's agree on that. Speaking of progression, so in early or doubtful cases, documentation of progression is key to diagnosis. That is, we're speaking of change over time, and hence it is mandatory to keep an accurate, dated record of the patient's visit to manage glaucoma. And any change in the examination, in order to be valid and judged as valid, has to be confirmed on at least 2 separate occasions. Except in advanced glaucoma cases in which the diagnosis and the stage of the disease is quite evident, glaucoma diagnosis is not a cross-sectional. That is, it is not possible to diagnose glaucoma with certainty from a single encounter with the patient. It rather requires multiple, on the average 3 encounters or examinations of the patient. The diagnosis of glaucoma in itself follows the classic triad of the intraocular pressure, the optic nerve, and the visual fields, of which the optic nerve head, I believe, is the most important of them. Nothing is not important, but let's say the major determinant is the optic nerve appearance. It is the major determinant of glaucoma diagnosis and management. And except for advanced optic nerve glaucomatous damage, no treatment steps are taken in the initial encounter with the patient, the very first meeting of a patient that might be glaucomatous. So, in another situation, another practical scenario, a colleague or a junior colleague or a resident brings up a file of investigations that just simply asks, what do you think about this visual field? And my answer would be simply, a visual field data should not be used alone in isolation of the clinical findings to make judgments and decisions. And only reliable fields should be used. If the reliability indices in reading the visual field are not adequate enough, this visual field should not be used to make decisions. It is necessary to repeat the visual field testing, both for establishing a baseline, if this is the first field of the patient, and for documenting progression if we're following up a known glaucoma patient, And at least 2 reliable fields at short intervals, let's say 2 to 4 weeks intervals, are needed to document progression in cases of follow-up of a known glaucoma patient. And irrespective of the intraocular pressure, any progressive visual field defect typical for glaucoma is diagnostic for glaucoma. So these are the important practical issues pertaining to visual field data. Like, as a simple example, like this patient, we can see here an inferior arcuate scotoma coupled with a superior notch. This is a clinically matching visual field with the optic nerve appearance, coupled with, of course, the history and clinical data, the remaining clinical data of the patient. This is one of my known patients. Okay, so we've mentioned discs, visual fields, progression. So I'm a little bit dazzled or puzzled. So where to start? Okay, so let's agree that the most common presentation of most primary glaucomas is asymptomatic. Most common presentation is asymptomatic. Hence, a high degree of suspicion should be there in order not to miss the diagnosis of glaucoma, not to commit the mistake of missing a diagnosis of glaucoma. So we should search for a glaucoma patient. So where to search for? Well, we can start by screening first-degree relatives of known glaucoma patients, or alternatively, we can screen all individuals above 40 years of age. These are just suggestions. Of course, there is no ideal consensus. There is no consensus about the ideal glaucoma screening program worldwide, but let's say these are just suggestions. Once glaucoma has been suggested to the patient, because not uncommonly we have a patient in whom another colleague or another examination or maybe some Google search has suggested to the patient that he or her has glaucoma. If this is the situation, then it has to be excluded by multiple examination visits, let's say at least 3 visits that are adequately spaced, in which every visit, every encounter with the patient, we perform a complete examination, revise all findings, and confirm every finding to make sure that they're okay. Since we're speaking of documentation of progression, visits, multiple visits, so the question would simply, how frequently do I see the patient? That is, spacing of the visits. When will I tell the patient, come to me next X of time? Well, this will depend on 2 issues. What is the aim of the visit? Why am I telling the patient to come back to me again? And the disease severity if we're speaking of a glaucoma patient. If we're doing this for the initial diagnosis of a glaucoma patient or to document progression, then we need short intervals, let's say 2 to 3 weeks or something like that. If we are following up a known glaucoma patient who is stable for a long time, we can space it for longer intervals, let's say 4 to 6 months, for example. This is about the aim of the visit. What about disease severity? Of course, logically, the more severe the condition, the closer the visits and vice versa. So what are the determinants of disease severity? Well, these are multiple. Let's say advanced cupping, The numbers you're seeing on the screen are just arbitrary suggestions, not evidence-based, of course. Let's say advanced cupping, 0.6 or 0.7 cupping, intraocular pressure that is considerably elevated, advanced reliable field changes, as we mentioned, only reliable fields should be used, advanced diminution of vision that is attributable to glaucoma, and another, I would believe it's a determinant of severity, which is a one-eyed patient, irrespective of the cause of loss of the other eye, that is it meant. So now we've introduced a lot of issues. So let's put this into a 1, 2, 3 step approach. How to proceed with the patients? Well, the diagnostic workup follows the same as the undergraduate scheme. The sheet with the holy trinity of diagnosis in medicine, which is history, examination, investigations. Any part of this triangle suggestive of glaucoma would be a clue to start searching for glaucoma. So discussing the history, for example, stressing the fact that most primary glaucomas present in an asymptomatic manner and are discovered by a thorough search by the ophthalmologist rather than by the complaint of the patient. But let's say these complaints are suggestive of some types of glaucoma, for example, pain in the eye, signifying considerable elevation of intraocular pressure or other inflammatory process that may be associated with glaucoma. Likewise, headache, blurring of vision, colored halos around light signifying edema of the cornea from whatever cause, angle closure, pigment dispersion, or whatever. Inapparent objects in the periphery of the visual field signifying a peripheral visual field defect irrespective of the type of glaucoma, missing letters of words, frequent change of near glasses. What about the other items? The second item of the sheet after the complaint is the history of the present condition. Notice that we're following exactly the same scheme of the fourth-year undergraduate students. The onset may be rapid, as in cases of angle closure or attacks of inflammation, neovascular glaucoma, or maybe gradual, as in most primary glaucomas or even secondary chronic glaucomas. The duration, it may be long continuous, as in most chronic glaucomas, or in attacks like pigment dispersions or sometimes neovascular, or of course the classic example of acute angle closure. What about the course? Progressive? Yes, this is the major issue of glaucoma. It's a progressive disease, or sometimes the complaint or the problem may occur in remissions and relapses like the typical attacks of angle closure again. What about aggravating and relieving factors? Pain that is aggravated by dark and relieved by light or sleep is typical to primary angle closure. Headache in the early morning may be typical to primary open angle glaucoma with marked elevations of the intraocular pressure. Other associated symptoms. What about redness, diminution of vision, with or without vomiting, characteristic, of course, of acute attacks of angle closure. Colored halos around light with minimal pain, characteristic of, for example, Posner-Schlossman syndrome, glaucomatous-cyclitic crisis, and things like that. All these are parts of the undergraduate sheet suggestive of glaucoma. What about the past history? If that thing or attack that the patient is complaining of had occurred before, this is another clue, similar attacks previously. What about the family history? We've just mentioned that diagnosing glaucoma in a non-glaucomatous patient is a crime. One of the reasons of being classified as a crime, I would say so, is because that family, any person in it would be treated as 10 times more vulnerable than the general community to develop glaucoma. So family history of glaucoma, whether a diagnosed glaucoma patient is very important, or similar conditions, let's say a distant relative or an old relative that has passed away, for example, and there are reports that that relative towards the end of their days was not seeing quite well. What about the drug history? Sometimes patients, especially in the community where we're practicing, we all know that some patients are not aware of the nature of the medications they've been prescribed or they're using. So they know that they're using this or that eye drops. They're not quite aware that these are IOP lowering drugs. Likewise, on the other side of the spectrum, IOP elevating drugs, in other words, steroids. Whether this patient is using already an IOP lowering drug that they're not aware that they are being given treatment for glaucoma, or whether they're using steroids and they're not aware of the potential complications of steroids, of which one of the most significant is elevation of the intraocular pressure in chronic glaucoma. So what about the surgical history? Likewise, some patients are not quite aware that the surgery they've done was to lower the intraocular pressure for a known diagnosis of glaucoma. Sometimes they just know that they've done surgery. So we need to ask about any surgery that is done before for glaucoma or otherwise. And we are all aware as ophthalmologists that one of the potential complications of both anterior segment and posterior segment surgery is elevation of the intraocular pressure in glaucoma. Therefore, surgical history is a significant factor in the clinical sheet or the history part of the sheet of the patient. So sometimes we're so happy to be spared all of this dilemma and say, I have today a glaucoma patient that is presenting to me already on treatment. It's my first encounter with this patient. The patient is already on treatment and he just comes for a second opinion or just to follow up and he's choosing to change his ophthalmologist. My lucky day. Well, not quite my lucky day, because my reaction towards that patient presenting already on IP lowering medications will depend on whether there is an accurate record of the pre-treatment baseline intraocular pressure. This pre-treatment or baseline intraocular pressure, this piece of information, it may be available or it may not be available. If it is not available, let's say, will depend on the optic nerve status, and we'll discuss this shortly, but let's say if the data is available and it is reliable. If it is available and it is reliable, we'll consider this value as the baseline value and manage accordingly. And I would better still recommend that we reassess all cases on first presentation if in doubt of the diagnosis, and if we are more in doubt, we manage as if this piece of information is not available and we check the optic nerve status. So what about the optic nerve if cases that are presenting to us for the very first time with the diagnosis of glaucoma already on IP lowering therapy, and there is no accurate record of the pre-treatment that is the baseline intraocular pressure? Well, we'll examine the optic nerve and we'll make an initial assessment. Is this optic nerve damage mild to moderate or is it advanced? If it is mild to moderate, I would personally choose to stop the medications and perform the washout. The aim is not only to confirm the diagnosis of glaucoma. Remember again, we're discussing a patient whose first encounter to myself as an ophthalmologist is this first encounter. This is not a known, this is not one of my patients whom I have known the history of the patient. This is my first encounter with this patient. So the aim to perform washout is to confirm the diagnosis of glaucoma and also to determine the baseline intraocular pressure, because this will help in setting the target IOP. In order to answer the very important question that the patient will ask, if not in the first visit, in later visits, is this level of IOP, is this number that you're telling me, doctor, is it suitable for my nerves or not? We cannot answer this question without setting a target intraocular pressure. And in order to set the target intraocular pressure, we all know that we must know at which level the optic nerve, which level of intraocular pressure has the optic nerve been damaged. This is the importance of knowing the baseline intraocular pressure. So how would we perform this washout? We would stop the medication, examine the patient every 2 weeks for 6 weeks, bearing in mind that the longer the treatment period and the higher the dose of the drug that was used before, the longer the washout period may need it, and the darker eye needs act as depot structures to the intraocular pressure lowering drugs, and so they need longer washout periods. Now the real dilemma is with that patient who's coming to me as an ophthalmologist, the very first encounter, the very first time, using already IOP lowering meds, the optic nerve state, I do not have information on the baseline intraocular pressure, and the optic nerve is advancedly damaged. This is the real issue that may be controversial, may not be that clear, in which case there's the problem, the scientific and the ethical problem. Would we take the risk of stopping the intraocular pressure lowering medications with such an advanced optic nerve damage? Maybe not. Maybe we would choose to continue the treatment even if in doubt of the diagnosis. And the only non-invasive investigative tool would be neuroimaging. Maybe this is a neurological damage of the optic nerve, not glaucomatous. Maybe, we're not sure. But I doubt that we would have the courage to change the intraocular pressure lowering therapy with such advanced optic nerves. So this is the history part of managing the patient. So are there any issues related to the examination? Well, yes. The same principles. An initial encounter usually provides only a provisional diagnosis. Multiple examinations are needed, at least 3 examinations, except in advanced, obvious diagnosis cases. And since we insist on an odd number of examinations, meaning 1, 3, 5, things like that, in order to, it's just like the vote. If the findings are different, we consider the predominant findings valid. That is, if I have two findings that are close to one another, and one finding that is two visits, I mean, with findings that are close to one another, and one visit with a different finding, then the visits with the two close findings are more likely to be more reliable than the visit with one different finding. If there is a consistent variability in the examination, then this is enough evidence of glaucoma, because one of the diagnostic features of glaucoma is considerable fluctuation of the intraocular pressure. So this in itself again would diagnose glaucoma, and this would add to the let's say the validity or the obvious importance of repeated or multiple examinations. The items to examine are the classic textbook items: the optic nerve status, the intraocular pressure, the gonioscopy, and consider the risk factors. The optic nerve status, as we all know, there are signs suggesting glaucoma and signs that make glaucoma unlikely. For example, a large cup-to-disc ratio, asymmetry of the CD ratio, thinning of the neural rim, and this is best assessed by, of course, the disc damage likelihood scale as we've enjoyed in these webinars a few weeks earlier. If there is a focal notching or a splinter hemorrhage confirmed by retinal nerve fiber layer defects, there are findings that are against glaucoma, which is, except in advanced cases, of course, marked symmetry of the neural rim, because glaucoma is rather an asymmetrical disease. If there is a marked symmetry of the neural rims between the both eyes, this is rather, it makes the diagnosis of glaucoma a little bit skeptical. And the large size of the optic discs measured by the slit lamp reticle, of course, raises the suspicion of a physiological cup rather than a glaucomatous cup. Intraocular pressure, again, we've enjoyed in these webinars to know that applanation tonometry is the gold standard. It is, of course, mandatory to document the time of the day in order to avoid diurnal fluctuations. Consider the central corneal thickness whenever available, and the suspicious patterns, above the statistical normal of 21 millimeters mercury, a considerable difference between the two eyes, considerable fluctuation over the day, diurnal fluctuation. There are some ophthalmology centers that would admit the patient for 24 hours and perform a phasing every 2 hours and draw a curve. There are actually some places that would do this, I know of them. Or if somewhere in our practice we're available anytime between 6 and 10 a.m. and we examine the patient at that time and measure the intraocular pressure, this would be a nice opportunity to demonstrate an early morning elevation of intraocular pressure, which would be suggestive of glaucoma or suspicious of glaucoma. Again, we've enjoyed the total webinar about gonioscopy, but let's just mention a reminder. We have the Goldman versus the Zeiss design. The Zeiss design allowing us to perform indentation gonioscopy. It's a must on initial presentation. It has to be repeated at intervals in order to revisit the initial diagnosis, recheck, as well as to check progression, because we know that angles get shallower with time. And the Zeiss allows the indentation, as we've mentioned. Risk factors that are reported for glaucoma, of course, family history of glaucoma of any type. Again, for the third time, this would stress why is it criminal to diagnose glaucoma in a patient who is not glaucomatous, because this would count on the family, a first-degree relative of glaucoma, which would change the look for the members of the family for the rest of their race, I would say. High myopia, as we all know, is a risk factor. Dark race, some risk factors of ocular hypertension, like thin central corneal thickness, large cup-to-disc ratio, and high intraocular pressure. And I would add to these, in communities where mobility is limited, inability to comply to regular and close follow-up, I would add this as a risk factor. These parameters could be compiled in this flow chart. As you can see, of course, we've mentioned all these in our talk, so we're not going to go through these details. What about the investigations? Let's pass on them. Just a quick review. Central corneal thickness. We know that thinner corneas raise the suspicion of glaucomas. Field of vision, and we've enjoyed the webinar about that. Fundus photography, the optic nerve red and red-free photo of retinal nerve fiber layer, anterior and posterior segment OCT. Each of them enjoys or provides a list of valuable information about glaucoma. Confocal microscopy. So, am I ready? Well, not yet. Let's take another 2 or 3 minutes to discuss what we call a special situation. A special situation is a condition in the eye or the general condition that has an impact on the diagnosis and or the treatment. Example, any media opacity, corneal lesion, pupil size issue, lens issue, vitreous issue. Regardless of the condition, Applanation tonometry remains the most reliable. If the cornea is markedly damaged, indentation tonometry would be reliable. If we cannot rely on the intraocular pressure, we can rely on the pupil reaction, visual performance of the patient. For previous refractive surgery, we're going to have a special webinar on that, so we'll postpone discussion of that for now. And at the end, after performing all of these efforts, and at that time, if the diagnosis is still in doubt, then I have a relieved conscience that I've done an effort to solve the patient's problem or dilemma, and at then only I'm allowed to manage the patient with informed consent of a guarded prognosis and uncertainty about the results. Classification of glaucoma, as we all know, is chronologically childhood versus adulthood, open versus closed angle, acute versus chronic, or etiologically primary versus secondary. So by this I conclude by stressing the importance of keeping an accurate, complete record of every detail in the patient condition, because this is extremely important. And if in doubt, please recheck, and follow up. And thank you very much for your attention. Thank you. Dr. Ahmed, you're muted, sir. Please unmute.
Sorry, thank you very much, dear Dr. Nader. This is a very informative talk. الحقيقة نحب نقعد مع حضرتك نص ساعة كمان أو ويبينار كمان. It's very rich. وهو الحقيقة you mentioned this statement which you repeated, and I probably heard this for the first time from you, that diagnosing glaucoma in a non-glaucomatous patient is nearing a crime. So
Professor Adel Hassan, from our late professor, Professor Adel Hassan, Allah yarhamu.
It is very true, and unfortunately we see many cases who come to us with glaucoma.
It's in common practice.
They stay with us maybe for months until we can tell them again, no, you are not
confidently they are not glaucomatous.
I think everybody of us sees these patients very well. We have some questions. Probably they will be shared with you and Dr. Adel. One question: could we depend on OCT to detect the progression instead of stopping medications? So I think you mentioned stopping medication in a different context. So if you like to highlight this.
Yes, sir. We've had a separate webinar about relying on OCT in detecting progression, but the issue is progression. Stopping the medication is not only for the diagnosis of glaucoma, it's to set the target IOP. So we cannot simply, it's not just to tell the patient that I'm sure that you have glaucoma or I'm not sure. The issue is to answer the very important next question, which is, what is my IOP today, sir? It's X. So the next question would be, is this X suitable for me, sir? I would have to say, I have to know, so what was your pressure before using the meds? So it's not just relying on the OCT instead of stopping the meds. It's a different issue. We rely on OCT. We may or may not rely on OCT to detect progression, whether we're using the meds or not. We stop the meds to confirm the diagnosis or to set the target IOP. It's a different issue than than following up with OCT.
Okay, I'll ask you another question. Do you have an estimation, so when you see a patient, for example, with an IOP of 18, and then he is receiving these 2 or 3 drugs, like a combination drug and then a prostaglandin analog together, can you give an estimation of the IOP of this patient without medications? Can we give this even rough estimation, or it differs from one person or one patient to another?
Of course, there's a very big difference from one patient to the other in the response to IOP lowering meds. Some patients get a really good response. So this 18, if you stop it, the patient might be, for example, 35 or 40 sometimes. And they have a marked response to IOP lowering meds. But there's another issue that was not actually discussed in the presentation, but I would highlight here since this question came, which is the issue of compliance or adherence to medication, sir. Not uncommonly, we receive a patient who is reporting to be using meds, and on thorough, close questioning and spending some time with the patient, you get the notion, sir, that the patient is not compliant or is not quite adherent to the meds. So these 18 is not actually in response to these 2 or 3 meds. Maybe they're using one only, maybe they're not using them regularly. So if that patient is using them regularly, there's a marked variation. Actually, this 18 sometimes turns out to be 25, 26, and sometimes not, which is mostly the case, and sometimes it turns out to be 30 something. But definitely, yes, with practice, sir, yeah, you can estimate the baseline IP, but I would not recommend relying on that at all. Evidence is to follow the rules, which is to stop the meds if the optic nerve status permits that, to actually get out with a number, not an estimate or an experience-based figure. No, an actual measurement of the patient, of that specific patient.
Yes, to hear, except in the situation where the optic disc is very
advanced,
compromised, so you can tell. Please tell us how can you determine, or how can you predict the compliance of the patient? You are giving this patient a Twinzol or a different eye drop, and then is this, how do you help yourself to detect or compliance of this patient?
That's a tricky issue. Simply, the glaucoma patient is not, let's say, a hit and run issue. The glaucoma patient must spend a significant amount of time with the physician, at least on the first encounter. The first issue, you get a glimpse of the personality of the patient. Is this type A personality who is very, very tense and very, very worried about their disease and using the meds regularly or not? First issue. Or is this, for example, an old patient who is a little bit drowsy, a little bit of cognitive problems of old age, and they're not following up? Or is this an overwhelmingly busy patient in their work, or their family indulged in them and not actually caring for their health? The ophthalmologist gets this general impression about the patient while interviewing the patient. That's the first issue. Second issue is the social conditions of the patient. That is, it is mandatory to go into a little bit of private issues of the patient. Are you living alone? Is someone living with you? That person who is living with you, you talk to them actually. Who is taking care of this patient? Is someone giving them the meds regularly? Is someone insisting on checking that they've taken the meds or not? This gives a clue. This is from the history part of the patient. From the examination part of the patient, with all due respect to IOP lowering meds, they do have side effects which are almost universal. That is, if a patient comes in with a very healthy ocular surface and with an eye that is whiter than my white overall, then this patient is very unlikely to be using a prostaglandin analog or a carbonic anhydrase inhibitor, which we know causes some redness in the eye and discomfort and a little bit of that closed eye. And if we're speaking of prostaglandin for a long time with long eyelashes, these side effects, if they are really not seen in the patient's eye, this is an issue of real doubt about the compliance. Plus, the last issue would be the known response of the common things are common, the famous dictum in medicine. So if we know that a certain medication is quite effective, and the patient takes the medication and does not show up the expected response, this would raise the possibility of non-compliance. If we, after confirming the compliance, that there is no response, then we diagnose this as no response and we follow the algorithm of either substitute or add or things like that. But first probability is to recheck the compliance again and again, raise the awareness of the patient, spend some time interviewing and talking to the patient of the importance of the compliance. So it's that, the character of the patient on the encounter, the social circumstances around the patient, the known side effects of the patient, of the medication in the eye, and finally the known response of the IOP to the medication. These are the 4 clues that I personally rely on. I think so.
And if I make, of course, you mean, or I confirm one of your points about the interrogation, you are actually like an interrogator to the patient. And sometimes, are you compliant on this drug and this drug? Yes, sir, I'm very compliant. So, I mean, one of the easy tricks is that you hold the bottle of the eye drops and tell them, okay, and let me know, when was the last time did you put this one? And then he just said compliance, but it was 2 days ago, sir. So
Yes,
I
sir.
mean, this is
Exactly.
one. I mean, you act as a detective sometimes.
Yes, thank you, sir. That's a great trick. Thank you.
Yes, Dr. Nader, we have a couple of questions actually on the target IOP. I know this is an issue which I mean take hours to answer, but maybe if you can give us a rather concise answer about how to determine the target IOP.
Okay. There's a definite equation that is evidence-based. I don't recall right now, but there is a definite equation that takes into account the rate of progression of the disease. But let's say a rough estimate now. The concept is simply the level of intraocular pressure at which the optic nerve would tolerate. Most studies would agree on a 30% initial reduction or a 30% initial target of the IOP. So if, for example, if I have an initial presenting intraocular pressure of 30, 30% of that would be 9 millimeters mercury. So I'll go to a pressure of around 19, 20, 21. And then we retest if we manage to bring the eye to that level of intraocular pressure, we retest the response, the optic nerve, whether by OCT or by whatever, or by clinical examination, and the visual field. If they're stable at that level, then we're set at this target level. If we're not stable, we set a target level, a target IOP at again a lower level. So I would say a clue is to start at or aim at 30% reduction of the baseline intraocular pressure. This is one school. The other comment to add is that in case of moderate, not moderate, let's say advanced optic nerve damage, the rule is to remain in the early teens, 10, 12, 11, 13, things like that, irrespective of percentage of the intraocular pressure reduction. And third, most important thing to stress is this is a dynamic issue that has to be constantly re-evaluated with the patient. It is not one decision to be taken at the beginning of treatment and forgotten later on. But there is a clue, there is an equation that takes into account the definite numbers and the rate of progression. I just don't recall right now, but it's there.
Okay, thank you very much, dear Dr. Nader. And the last question, actually, it is both a statement and as much as it is a question. What is the importance of counseling patients for the future of their lives with their glaucoma as to be regarded as lifelong disease? Counseling with the patient and the
this is like, yeah, and this is I don't know. This is what is the importance. It is the single most important thing to do. It is like, I don't want to use big words, but I would liken glaucoma to cancer. The patient has a right to understand that if they do not comply to their treatment, they're going to go blind. It is not simple. It is not a disease with all due respect to all specialties and other diseases, it is not a disease to be taken lightly and that this disease is just going to cause you some little bit of discomfort and that's it. No, it has to be stressed that this is a blinding disease, and if the patient is not aware through counseling, through thorough counseling, that they're going to go blind if they don't comply to treatment, this is another crime that to be done for the sake of the patient. If the patient is not given full information about the gravity and the prognosis of glaucoma that they have, we've done a big crime in the sake of that patient. The patient has to understand one concept: you have a blinding disease, and unless you comply with the treatment and the thorough follow-up, it is not, I don't want to say a slang sentence, yani it's not something to mess up with. It is something that has to be taken very, very seriously. Not to terrify the patient, on the other hand, of course, and this is the importance, as we've mentioned, is to grab an idea about the personality of the patient. We get the impression, you know, your patient after some time. Is that the type that would panic if they get a piece of information, and when they panic, they would lose their control? Or is that the type of patient that would be adequately informed of their disease and react adequately? The social part here cannot be overstressed. It is really, really extremely important. It's a real issue. It cannot be missed. I'm sorry I talked a lot about this, but it's important.
Thank you very much, Professor Dr. Nader Bayoumi of Alexandria University. Thank you for this very informative time we had listening and hearing your talk. and I leave for a minute with Orchidia and the technical support now, and to come back later.
Hello, doctor. Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. I'm going to talk about dry eye patient, especially who is associated with itching. Orchidia offers the integrated solution from Orca-P-Post and PolyFresh Extra. Orca-P-Post is anti-itching and anti-allergic agent, which is not only has exceptional antihistamine effect, but also has a novel special mechanism as anti-itching agent by inhibiting nitric oxide secretion at nerve endings. The second arm of our solution is PolyFresh Extra, which is a unique combination that gives extra hydration effect and balancing the tear film osmotic pressure, in addition to the anti-inflammatory effect of glycerol. Thank you for your time.
So now it is my pleasure to introduce Professor Dr. Adel Abdel-Shafik, one of our teachers, whose very methodical thinking and teaching along the years have taught many generations of glaucoma specialists. Dr. Adel has a long arm in the glaucoma management and diagnosis. Dear Professor Dr. Adel Abdel-Shafik, professor at Ain Shams University, is going to talk us through the staging and the progression of glaucoma. Dr. Adel.
Dr. Ahmed. Let me share my screen. Okay. I think now I can start my talk. I don't know why I'm seeing. Okay. Do you have my screen? I don't think.
We have actually your, yes.
Yes,
so now
that's
probably
it.
it's coming.
Yes, yeah, okay. That's it. Right? You have it now.
Yes.
Okay. My talk about staging and progression, should we depend on structure or function? What is the value of each? Is anyone is more important than the second? Diagnosis of glaucoma depends on so many factors. My talk will depend on only these three: the OCT, the field, and the disc. To stage the amount of damage is important because it's one of the factors that will help us choose the target IOP. So we need to categorize our patient, is it a mild or moderate or severe damage? Other factors can be included and should be included, but just this part is part of the parameters. Sometimes people depend on the field of vision or the optic disc or both. There are so many systems like the old one of Parrish Anderson back to 1993. And then we have these two systems, the American guideline and the Canadian guidelines. Later, there are other systems like the glaucoma staging system 1, glaucoma staging system 2. I'm going just to keep an eye on the American and the Canadian guidelines. The American guidelines classified the amount of damage as that. Early glaucoma is a patient with characteristic optic disc anomaly, and the field is totally normal. White on white field is normal. Moderate glaucoma is a characteristic optic nerve anomaly with field anomalies in one of the two hemispheres, either up or down, and no affection in the central 10 degrees. Severe glaucoma means affection in the field up and down, or affection in the central area. As you can see, they just get the optic disc anomaly out of the way. They depend totally on the field to put the patient either as a pre-perimetry glaucoma in the early stage, or moderate or severe glaucoma. So if you have it here, this is a totally free field, but with disc changes, they consider this mild or pre-perimetry glaucoma. Moderate if you have changes in one of the two hemispheres, but the central part is not affected. In case having affection up and down or having affection in the center, then this is a severe. If we come to the Canadian guidelines, they defined early glaucoma by having field changes. They describe it as early field loss together with mean deviation less than 6 and cup disc ratio less than 0.65. Moderate glaucoma, you have significant field changes. We didn't decide what is significant, but the point is the central 10 degrees is not involved. Second, mean deviation between 6 and 12, and the cup disc ratio from 0.7 to 0.85. Severe glaucoma when there is affection of the central 10 degrees, or mean deviation more than 12, or cup disc ratio higher than 9. So, affection in the field up and down, but not much, they consider it mild. Extensive affection, but the center is free, they consider it moderate. Affection in the center, they consider it severe. Then they add the mean deviation, and they depend on the cup disc ratio. As you can see, there is no agreement between the systems. So for me, I just have all these in my mind, and I always go and choose the severest part and go for it. Whenever I have changes in the central part, this is severe glaucoma. If there is affection up and down, I prefer to use the American type, it's severe, and so on. If you have some changes in one of the parameters and the other is not supporting, I usually choose the severest one to build my decisions on. Now, structure and function. Sometimes you see OCT changes only or disc changes only. Sometimes you see field changes only, and sometimes you see them together. When they are both together, this will increase our confidence in the diagnosis. So both structure and function help us with the diagnosis, the staging, and the progression. Before checking the field of vision or OCT printout, keep in mind these points. First, keep in mind to be free of pitfalls and errors. For example, you need to have the same field changes repeated 2 times to make sure that it is real. In this example, this is the field with the repetition, everything disappeared, so it's not real. So you need to confirm changes on 2 reliable disc examinations. This is not only in the stage of early learning curve, even all over the disease, whatever the stage is, I don't accept any changes being real unless I see it in at least 2 further fields. For the OCT, you need to make sure that the signal strength is fine, because OCT with low signal strength, you get low data. Each machine got its level of significance. Below that, you don't accept the results. And you have to memorize all these numbers. The Ceres, the Stratus should be 6 at least. The Spectralis should be 15 at least. The OptiView should be 40 at least. The Topcon should be 45 at least. Sometimes the new printouts, it's already highlighting for you in green or red or something. Again, in your mind, not every red and yellow is a disease. Simply because of the limitation of the normative data, maybe your patient is outside of all these ranges of the normative data. Again, I'm going to show you 3 articles. They were done on normal persons, and they agree that in a normal person, we may face changes in the OCT and the RNF or in the ganglion cells in 1/3 to 1/4 of the patients. This is the first study. Around 150 healthy persons, they get around the disc disappearance of red and yellow in almost 1/4 of the patients. This is one of the examples with normal disc normal field, but the OCT have these changes. Another study showed that comparing 131 eye with glaucoma, early glaucoma, mean deviation less than 6, they get this appearance in the ganglion and the macular area in around 80%, this appearance in around 90%, this appearance in 80%. But again, in the same study, around 132 normal persons, you have these appearances in 20%, 28%, 15%. So whenever you see such a thing, don't rush for glaucoma. Again, the degree of error in that study or simple myopia, maximum 4 or 5 diopters. The third study was done on 104 patients. They found changes in the ganglion cells in 40% and in the RNF in 30%. These are some of the examples of that paper, such changes. They don't accept this as real because they are missing changes around the disc. And they advise, this is the typical for glaucoma, that the changes are temporal to the fovea. It respects the horizontal raphe, and there is a corresponding RNF changes to that area, and it is arcuate or crescent in shape. If you have all these data, then you are sure more that it's a real thing. Again, this was the first point. The second point, check for asymmetry. Glaucoma is typically a bilateral disease, but frequently asymmetrical. Visual field and OCT defects are commonly asymmetrical at the time of diagnosis. Asymmetry can be between right eye and left eye, and asymmetry can be between inferior half and superior half. So keep in mind any presence of asymmetry. For example, in the OCT, you get a comparison between right and left eye. This is abnormal. Or even in the table here, you can find this parameter, RNF asymmetry. Again, in the Optic view, you have right and left eye, and the difference is shown up here. And even in the spectralis, they are comparing right to left. And this part, they are comparing these with those, and each one with the similar on the opposite side. And you have this clue, right to left comparison, and on this side from left to right. In the lower part, they are comparing inferior to superior. That is for this eye, they are comparing this row with that, the next one with that, and so on. And in the upper half, they are comparing from up to down. So this will draw your attention, there is something is going on. In this example, I've got it from the internet. The author there, they show that there was asymmetry between in the right eye, between the superior and the inferior. Although everything looks fine, everything is perfect, then on the examination, there is hemorrhage, and in the field, there is field changes. So this is a green disease. If you can miss it, unless you check this point of asymmetry. Again, in the Humphrey, we get the glaucoma hemifield test comparing each sector with the corresponding one. If one of these sectors, the difference between the one up and one down is found in only 1% of the normal population, you get this term outline normal limits. If it's present between 1% and 3% of the normal population, you get a borderline. So the third, you need to check for areas constant with the glaucoma. In the field, glaucoma can be present as a generalized depression, but usually it is very rare to be alone. Paracentral scotoma, sometimes we have difference between me and my friends, doctors, where is paracentral? So the central 5 the central 4 points. This is the center, and outside it, I consider it paracentral. In this example, this is a little bit out. It's the third one from the center. So it is somewhere between, say, 9 degrees or so. The third is nasal step. The definition of nasal step is you have a relative depression in one of the two hemispheres. Like this, you have changes in one side and not in the opposite side. This is nasal step. Like in this example. And again, being up, nothing down, this is nasal step. Arcut or germsctoma changes between 10 and 20 degrees. This is the blind spot, so we follow it. Again, this is arcuate, but it's getting paracentral as well. Lastly, altitudinal defect is one of the things of glaucoma. It's the arcuate getting to the center, paracentral, and central. So again, this is one of the possibilities. In the octopus, they put the test points in special location following the nerves, then they can diagnose glaucoma. And in the new software, they depend on clusters. They collection of points together and add them and compare them with the normal population. If the addition result in a low probability, then it is highlighted for you. This is area, get a probability 1% or 5% and so on. In the OCT, where are the points to look at? You need to look at the average retinal nerve fiber layer thickness. This is the highest parameter to diagnose glaucoma. Then clinicians should look at the superior and the inferior rim. This is the second frequent area. Again, if you examine the macula in the OCT, if you have a lesion that is respecting the horizontal raphe, this will heighten the possibility of the glaucoma very much. Again, Hood et al., they documented this area just temporal to the fovea, arcuating like this, and they found the affection of this area is very commonly affected or associated with changes here in this area of the disc and the parapupillary nerve fiber layer. And they call this part macular vulnerability zone of the disc. So this area, if you have changed in it, consider most probably you have changes as well here in the macula. And they say that this location is a very common location for the occurrence of hemorrhage, disc hemorrhage. Further group, they published again in 2017, and they show that all cases with affection in this area of the papillary nerve fiber layer were associated with changes here in the macula. On the OCT, you can check it here. This is the area to check for that location, or in the map, you can find it here. Again, if you have changes in the macula going on with the changes on the around the nerve, then you are more certain of the diagnosis. And recently, you have a printout of both zones. Here, this is around the disc, and this is the macula. And there is changes, and they are following together. Although the retinal nerve fiber layer alone, you can only have some changes here. And the ganglion cell inner complex layer, everything looks green here, but this is a sign. So as you notice, not everything should be appear together. Any one title thing will push you to the possible diagnosis. Lastly, you need to correlate between the visual field and the OCT. You have to know the anatomical locations. This is the famous work of Gerway back in 2000. He located the 24-2 of the Humphrey on the fundus. These 6 points, they get access to the nerve or the retinal fiber layer here, and this 90 degrees. This part of the field up and this part down, they get in these 40 degrees. The up will be here, the lower will be there. Then the remaining part of the field will get into this area of the retinal fiber layer. The remaining 4 points nasally will end up nasal part. So this area is the most important to keep an eye on because this is the arcuating area for the glaucoma. So keep an eye always on this area, inferior, or this area, superior. In the clock hour, they are there. Not exactly at the clock hours, but this is the locations of the inner parts and this is the outer parts. You have to keep this in mind. So if you have changes with several points together with the field, then you are sure more with the diagnosis. I'm going to show you some of the examples. Here you have damage in the lower part. If you check the OCT, you have changes here in the inferior. This is the nerve fiber layer. This is the neural tissue, the disc, the neural rim. And this is the macula. You get things going on here together and respecting the horizontal, roughly, and the field changes going on, then you are certain of your diagnosis. Another example, the disc looks normal, OCT is fine, macula is fine, field is okay, but as you notice here, you get some changes and you have borderline, so this is a query. You need to repeat the field to keep an eye, just to be sure if for the second time field is normal, then you are safe. For me, this looks there be something here, but it is fine here. OCT is okay, no changes in the field. Another example, you have some atrophy here, striations here are missing. OCT shows change coinciding with that. Again, in the macula, it's going on, and field changes. Then you are sure of your diagnosis. I can skip that for the sake of time. Now, what about progression? We need to know what is the rate of progression. Keep this in mind. If you have your mean deviation, once it is below 14, this is visual impairment. If it's below 22, this is legal blindness. So we want our patient not to pass into this bad area by the end of their life. We want to keep them up here in all their life. Diagnosis can be done depending on event analysis or trend analysis. Event analysis means something is shining up in one location. Trend analysis is the rate of change over the time. Let's see how to do it in the field and how to do it in OCT. We should stop putting fields next to each other and say, yes, this looks progressive. No, we should stop that altogether. I want to convince you why we should stop that. This paper was published back in 1989. The author there, they got 51 patients. They were tested 4 times within 4 weeks. These patients, they got different severity of glaucoma between early and advanced glaucoma damage. And they found the following. Areas where the sensitivity were near normal, these areas get a fluctuation in the follow-ups in these 4 weeks between +3 to -7. Areas depressed by 6 than normal On the follow-up, the fluctuation was between +1 and -16. Areas were dropped sensitivity between -8 to -18 of the normal. They get fluctuation, the whole range from 0 to the full. So each location, the fluctuation varies. If it's near normal, the fluctuation is limited. If it's more depressed, the fluctuation is higher. If it's more and more depressed, the fluctuation is higher and higher. Again, in the central area, fluctuation is minimal, while in the periphery, fluctuation is more. Third, the mean deviation of the whole field. Depressed points in a generally depressed fields show more test-retest fluctuation than similarly depressed points in otherwise normal field. بمعنى, if you have two fields, the mean deviation in one of them is -1, -2. The second, the mean deviation is -15. The same values with the -15 general depression will fluctuate more than with the -1, -2 general depression. So they came up with these three things: the sensitivity of the location being center or periphery, and the mean deviation of the field. And this was the base on which they built the progression analysis and the Humphrey. The company makes such a map and then decide for each location certain level. If this is the first two examinations, and this is the following examination for each point. Once one of these examinations exceeded one limit, you get this triangle. If it is repeated twice exceeding this limit, you get this triangle. If 3 times, you get this triangle. What is this limit? This limit depends on the sensitivity, depends on the location, depends on the mean deviation. And this is what going to get. What about this X? Means that the sensitivity of this point is so depressed that the fluctuation is so high and we cannot tell what's going on. All this you cannot get it by looking into two fields. You have to depend on the machine. And again, if the mean deviation of the whole field is less than 20, then all this is not shown anymore because the general sensitivity of the whole field is less and everything is unreliable. And this is what you get in the printout. This is the first basal 2 tests, and this is what you have in the current, and in between you get this progression line. This was done before using the mean deviation, and recently was done using the visual field index. So event analysis focus on locations. It needs fewer fields to get an outcome, and you get this outcome quicker. Trend analysis, it shows you the rate, but it needs larger numbers of fields to get the result. I want to show you this, what's written here. Rate of progression minus 3.7% per year. And again, you have this plus minus 2.7. This is the confidence interval. I just want to know what's that. The confidence interval means that if we repeat the same test several times, we may get a value, this minus 3.75 might be something between -1 or down to -6.4. Minus 275, if you add plus 275 to this number, you will reach -1. If you add minus 275, you will reach that. So we are not certain for sure that the real slope is minus 3.7%. It can be something in this range. What is the value of Z? If this number is high, suppose that it can be, say, from +1 to -6, then you are not sure of this regression that it has a significance. This is something very difficult for us because we are not accustomed for statistics, but actually many of the values we have there are there depending on statistics, and we should have a minimal information of statistics. In this example, -9 plus -2. So actually, we are confident 95% that this curve or this line can be somewhere between -0.7 to -1.1. I just added minus or plus 0.2. Same here. This value can be varies between -2.5 to plus minus 3.5 by adding minus or plus half to this value. In the octopus, they making in the new software, making clusters and then following the clusters. If the variation between one visit and the following is occurring in 1% of the population, then they highlight in this is abnormal and this occurs in only 1%. This is abnormal, occurs in 5%. This is increasingly high and so on. So as you can see, if you depend on the machine, you will get information quicker and more certain. With some of the data, actually, you cannot do it by looking at the two fields next to each other. We got some parameters, again, with trend lines. Okay, progression, it is not sure what is the value of regression slope and what is the probability consistent with progression. They haven't agreed for that. And they haven't agreed whether they should be the changes on the fields next to one another or maybe one field on, one field off. Also, they have not agreed how many points should be included and how many points, whether they should be touching one another or not. So they haven't agreed at all at what is the optimal thing for the progression, but still all these algorithms, although not standardized, still are very useful to give us a proof of progression. Now, what about the OCT? You need, if you want to check, if you are comparing numbers, you have to be sure that the change is not due to inter-test variability from one test to another. Aging is not a factor important for us because we repeat the OCT every year and the changes is usually half a micron or so, or less than that. So we just concerned about the inter-test variability. So what is the real progression? I borrowed this slide from last week talk of Dr. Karim. He was showing the Zeiss and he showed us if you have an average, this is the inter-test variability. So if the changes is more than 5 or 6, then this is most probably progression. If you look for the hours, you need changes to be more than 12 to 15 microns. This is for the Zeiss. It may complicate things for you. For the OptiView, this is one of the articles in the net. For the average, you need at least 5. For the superior and the inferior ganglion cell complex, you need 5. For the quadrants, you need something between 7 to 10. But this is one of the studies. If you search more for another study, you will get some different numbers. For the spectralis, for the retinal nerve fiber layer, you need changes more than 5. For the macula, you need changes more than 5. For the neural rim in the disc, the Bowman's membrane, the Bruch's membrane opening, minimal rim widths, you need changes more than 13. Another study showed that faster changes than 1 micron is likely progression of glaucoma. They were talking about the retinal nerve fiber layer. Another study recently, still not even available, it's just online. They show the degree for the spectralis changes glaucoma progression is slow if it's less than 1. Between 1 and 2, it's moderate. Between 2 and 4, it is fast. More than 4, it is catastrophic. So here, this study shows that more than 4 is catastrophic. And here, they accept more than 5. So what to do? Do we have to summarize all this in our brain? If we depend on the machine can highlight that for you. One of the things in the spectralis, they compare 2 fields and they give us a change in the map, and as this change is showing arc width in this location, then we are more certain that this is more change. Again, this is over the time. You can see there is changes, and this is, you can see it here, baseline 1, baseline 2, and current. And if the current here is, this is the blue one is depressed here, and it's highlighted there for you. And you get the regression line for the thickness, the cup disc ratio, the superior, the inferior, and sometimes even here they give the answer to you. If it's possible loss, you get a yellow sign. If it's most likely happened several times, you get red. But notice here, possible increase. Sometimes you get a sign that there is increase in the thickness. How is that? This is an artifact of the technology. Again, another machine showing the same with the change over the time with the regression line. So to end up, I told you glaucoma diagnosis depends, it's a puzzle. This puzzle depends on many factors, but even these 2 factors only, the OCT, the visual field, the disc, each one of them, again, it's a puzzle. If you get so many things, if you had so and so and so, most probably the change in the OCT is real. If you have that with that and that, then the change is there. Because so many people ask us, okay, give us a flow chart. If you find this, we'll do that. If you find this, we'll say that. It's never like that. You have to spend so much time for each of the machines available. We should depend on the machines. This will give us more accurate results, and it will save us our time. But you have to avoid pitfalls and wrong interpretation. And also, you have to have a reasonable background of statistics. It is not difficult to achieve, but this will help us a better perception of the result. I advise you, I have 3 presentations on statistics. If you check my YouTube channel, just write my name on YouTube search, then check playlist, check field of vision. Then you have these 3 last presentations, statistics behind the field. Each is around 12 minutes. No equations, nothing fancy. For me, I'm an ophthalmologist, but I'm using a simple English language that will help us understand the statistics, and I invite you to see them. Thank you for your attention.
Thank you very much, dear Dr. Adel Bey, of this journey through the progression of glaucoma. This technology, Dr. Adel, we have actually a question about the ever-going question about the LASIK and the follow-up of glaucoma patients with LASIK. Do these machines, do these OCT evaluation and the progression, etc., do you think they are affected by the corneal curvature or by the LASIK surgery?
Yes, once your patient undergo LASIK surgery, you have to start a new baseline. A new baseline for the IOP measurement, better to go for the aura. A new baseline for the field, a new baseline for the OCT.
Yes. So do you think there is a difference between pre-LASIK and post-LASIK OCT, Dr. Adel?
Yes, sir.
Oh. So there is another question actually, but it can be for both of you about the follow-up and treatment of juvenile glaucoma eyes, because it will be something for a lifetime. So do you have anything to comment on that? Juvenile glaucoma, glaucoma in the young. So do you follow them up more? Do you require, and then we go back also to Nader, lower target IOP, etc., in younger eyes? People who are...
The difference will be the duration, because
Yes.
the lifespan is quite long. Then you build your decisions on that. Again, if it is successful at one time, maybe after a year, maybe after several years, it will be a failure. So you have to keep follow-up for life, and the difference in the management or for the choice of target IOP, I'm keeping in mind this patient is going to use treatment for a long time. Maybe he cannot keep on medication. For this, I will go for more surgery earlier than if the same patient is an older. So this is what is the difference for me.
So, and I'd like to ask you about the current database available in the newest machines for the youngest age available, and how far you can depend on that in younger populations, in teens.
الOCT youngest 18, السن 18 years.
But it's still 18, Dr. Adel.
Yes, I want to tell something about the field. The field is very reliable starting from the age 9 years. And I tell you, some of the research work, they train monkeys and they train very perfect to do the field. And they do the field, then they make sections in the retina and see the thickness and things like that. So the field you can depend on reliably for the young age starting from 9, like the oldest.
So if you have a glaucoma patient age 12 or 15, for example, you don't do OCT for them?
I can do it. No, I can do it, but I don't depend on the yellow and red. I just have it. Then this is my baseline. Then I
maybe
compare.
For future.
Yes.
For future evaluation.
May I add one thing, sir, about that?
Yes, please, Dr.
There are recently, I just don't recall the numbers exactly, but in late 2019 and in early 2020, there has been published literature about portable OCT in children, and they are starting to develop. The problem with the age limit for databases and machines is the age of legal consent. As you know, sir, it's 18 years. But that is why that's the secret behind the age limit being 18 years for both field and OCT. But recently, with the development of the portable OCT, there are published reports, perhaps maybe one or two, I don't quite recall, but they're in late 2019, early 2020, about OCT values for children. So in the coming few years, maybe in the coming few months, maybe, I think we will start seeing some normative data about children, maybe. If I may make a small addition to the question about juvenile glaucoma, if we're speaking about juvenile by the definition that is beyond 3 or 4 or 5 years of age, then it's like an adult glaucoma. All rules apply with with considering surgery more a viable option. If we're speaking of younger age than that, then there are the ocular biometric characteristics that change. And the axial length already changes, the corneal diameter changes. We're not here waiting for the OCT. The gross appearance of the eye changes. So if the question is about juvenile glaucoma with the meaning childhood glaucoma, the first 3 years, the eye itself changes all its dimensions. Beyond the 3 years or 3 or 5 years, the juvenile glaucoma is by definition, according to the CGRN definition now. So it's like the adult glaucoma, like Professor. I would go with Professor Adel's addition. Definitely yes. Sorry.
Okay, thank you, Dr. Nader. And the last question we have this evening is that for Dr. Adel about the very advanced cases of glaucoma. Can we assess the progression using the OCT in these patients?
The problem
do you find it useful يا دكتور عادل في advanced cases انك تعمل with every as you do in earlier cases?
The problem with the advanced stages is the floor effect. When you And the nerve fiber layer, if you reach down to 50 micron, you are left with glial tissue, blood vessels, so you cannot get more changes regarding the neurology. But it is said that in the macular area, the floor effect is delayed than that. So in the macula, maybe this will help, but routinely, if I'm so advanced, I will shift and depend on the field at this stage.
Okay, thank you. Thank you. Thank you, Professor Dr. Adel of Ain Shams University. Thank you very much. And I just would like to tell both our eminent speakers that we are having rave reviews and comments from our audience, and many of them are good glaucoma names, good national glaucoma names, and they are many of the audience, and some of them are glaucoma specialists. They are thanking you for your informative talks. Thank you very much. And I direct our invitation, ESG invitation, for all our audience to our upcoming episode 5 of Glaucomatology 2020. It will be on the specific glaucomas, exfoliation glaucoma, neovascular glaucoma, etc. It will be next week, and we promise you another informative and rich session, inshallah. So see you then, and have a fruitful week.